about emergency health care services in this country. And I started by looking at the policy and guidelines for hospital, accident, and emergency services in Ghana. But before we get into more of that, let's get on to the phone lines, because we've been joined by Richard Salome, who is General Secretary of the Ghana Medical Association. We've also been joined by Dr. Simon Nyaba, who's Deputy Director, Policy Planning and Research, Monitoring and Evaluation of the National Ambulance Service. So, Dr. Nyaba and Dr. Salome, good morning. Thank you very much for joining us.
Yes, good morning to you.
Okay.
And let me seize the opportunity first and foremost to extend greetings to our audience on behalf of the CEO of National Ambulance Service, the management of the National Ambulance Service, and the entire workforce of the National Ambulance Service.
Thank you very much.
Good morning.
Good morning once again. Dr. Salome, I'd like to start off with you, because I am looking at the guidelines on accident and emergency services. Because you are a medical doctor, it says emergency unit requirements in the hospital's triage area, functional resuscitation area for patient stabilization, transient area for patient observation for not more than 24 hours, procedure room for minor cases of theater, waiting room, ambulance bay. But I look at the triage, which is the process of quickly examining patients who are taken to a hospital in order to decide which ones are the most seriously ill and must be treated first. Dr. Salome, is this what applies in our hospitals?
Well, good morning to you, and good morning to the listeners. It is good that you are referencing the policy and the guidelines document. But there is always a translation from policy into reality.
Okay.
And Ghana has many beautiful policies and guidelines that, if implemented, we should not be cyclically discussing this matter of no bed syndrome and emergency lapses in emergency care and losing lives, productive lives, unwarrantedly. And so the truth is that what you have read, you can do a survey by yourself and go to the facilities and find out how many facilities have these in place and how many facilities even have standby oxygen in place and have the necessary professionals to ensure that they use these equipment logistics to be able to do the work that we have. How many emergency physicians that we have, and the various things that you've talked about. There is a real problem. And I think what is important now is to have a concerted effort. The public, the health system itself, and all other actors, including you journalists, to aim specifically at solving the problems and not, for example, rehashing the problems over and over again. So if you ask me directly, what happens on the ground is totally different from what exists.
So tell us what happens on the ground, Dr. Salome.
Well, you have an emergency system where there's a challenge with logistics. You have National Ambulance Service on the call. I am sure he will tell you the challenges of the operation, the number of ambulances that are available within the system, the issues of fuel, where we have to sometimes have banters with them, argue for hours trying to raise funds to pay people's bills so that they'll be able to be transported from one facility to the other. A disjointed emergency response system where moving from one facility, and there's no centralized point where we can know how many beds are available and where the patient for what service. Any real capacity system that can tell us this. There's also poor ambulance hospital coordination. And then, of course, when it comes to referrals, there's a big challenge in the full cycle referral system where a patient moves from point A, the next hospital they go to knows that they are coming and prepare for them. And then also at the receiving point, when they cannot receive this patient for some reason, how this is handled. There are multiple facets to this issue. There's also the challenge of dumping. No matter how many beds we provide in Kolebu, if all the periphery are dumping into Kolebu and are not strengthened, Kolebu will always have no bed. Ridge will always have no bed. Konfanoche will always have no bed. It is important that we begin to equip the peripheral facilities, both with human resource, the necessary logistics, to be able to handle a lot more of the cases as close as possible to the communities where the issues happen, with road traffic accidents or other emergencies, than be rushing them all to Kolebu, Ridge, and other 37 and other places. There is also the issue of understaffing, demotivated staff, and of course, in a few circumstances, individuals who may not do the right things. So there is all these issues, and in the center of it is also a population which has bad health-seeking behaviors and often would wait till the last minute or will report to hospitals in an emergency than go to the hospital early. And so all these matters mix up to give us a system that is very dangerous, that we must treat as a matter of urgency and cure.
Okay. Let me bring in Dr. Simon Nyaba, who is the Deputy Director, Policy Planning, Research, Monitoring and Evaluation at the National Ambulance Service.
Doc, good morning. This is Kojo Akoto Boateng here. So, how many ambulances do we have in the fleet of the National Ambulance Service at the moment?
Well, once again, good morning to your audience. As we speak, the National Ambulance Service operates a total of 318 ambulances across all regions and constituencies in the country. However, like any other agency that operates a fleet of vehicles, not all of them will always be in commission at any one point in time. And so as at yesterday, for example, in the morning, the availability report of ambulances nationwide is that out of the total of 318 ambulances are in commission, therefore 127 were out of commission as at yesterday in the morning. As at the time that I am speaking with you now, our operations directorate is tabulating or gathering information on the availability for today.
Okay, Doc, so you said you have 318 ambulances in your fleet. Out
Correct.
of the 318, 127 are grounded, they are not working. So how many are working at the moment?
Yes, that is why I'm... Hello?
Yes, Doc, we can hear you. Go ahead. Hello, Dr. Nyaba. Doc, can you hear us? Okay, we've lost Doc. We'll get him back on the call, but we still have Richard Salome and Kwame Sapon-Siedu on the line.
Yes, so let me get to you, Kwame Sapon-Siedu, and we've had this conversation before. We've had discussions about emergency healthcare in this country. But what really struck me was the fact that I'm looking at our policy and guidelines on accident and emergency. And I realized that we say it's important we have a triage here in this country. We talk about all hospitals needing to have a functional resuscitation area for patient stabilization, a transient area for patient observation for not more than 24 hours, procedure room for minor cases or theater, waiting area, and ambulance bay. Unfortunately, Kwame Sapon-Siedu, listening to Dr. Richard Salome, these are things we've put in a policy document, but have not implemented it. So what's our seriousness towards accident and emergency in this country?
Thanks, Winston, and good morning to listeners and Richard and to you, Kojo. Could you check the date on that document you're reading?
2011.
Does it not say 2011?
Yes, 2011.
Does that document not say that no accident and emergency unit should turn around a patient?
Yeah.
Okay. Do you remember a document called the Health Harmonization Assessment Facilities Assessment Report released in 2023, July?
Yes, I do.
That I shared with yourself,
Yeah.
Kojo Yankson, and
Raymond.
the other name has got Raymond
Aqua, yeah.
And we discussed at length. Do you remember that in that document, the first thing that struck Kojo Yankson was that 95% of our consultation rooms do not have the basic consultation and amperometric equipment to make an accurate diagnosis? Do you remember that?
Yes, I remember.
Okay. Do you also remember that in 2018, there was a letter written by now MP for Lambusie, my old friend and brother, and Dr. Titus Bayo about the same low birth syndrome?
Mm-hmm.
If you don't have it, the letter is dated the 14th of June 2018.
Yes, I think at the time when he was Assistant General Secretary of the Ghana Medical Association. Yes, I have that press statement.
So you realize what I'm saying? I'm trying to say that consistently, as a country, as citizens, as politicians, we have deliberately chosen not to deal with this problem. The problem is not a bad problem. I have had this conversation with you guys and on other stations so many times. It's a systems and people's problem. And it's a system problem because when we have a diagnosis, you see, health is fundamentally, you diagnose what the problem is, you intervene. So as a result of the intervention, you have what we call a prognosis, and based on the prognosis, you have an outcome. So when you have a patient, that's what you do. For the health system itself, that is what you do. The Health Harmonization Assessment Report was a diagnosis of the health of our health system. So is the Holistic Assessment of Health Program of Works document. They are a diagnosis of our health system. When the diagnosis of our health system told us our health system was very, very sick, we did nothing about it. In fact, there were politicians who looked at the diagnosis which said we needed retooling of our health systems. That was the diagnosis. But we haven't retooled since 2014. So if Dr. Salome is telling you that those haven't been implemented, it's true, we've not done retooling since 2014. That is a fact of our health system, and that was why we had that bad diagnosis in 2023 from the Health Harmonization Assessment Report. But you know what, Kojo and Winston, when that report came out, how many journalists discussed it? How many? You see, we have a country where when we know what is wrong with us, we don't deal with it until we get the poor outcome. Because like I said, the intervention leads to the prognosis, and the prognosis tells you what the outcome is. Sometimes the outcome can be fatal. But when we have the outcome that is fatal, like has happened to this gentleman, unfortunately, we shout like we're doing now, and we then go and deal with the symptoms. So yes, I see a letter saying that 2 doctors and 2 nurses have been interdicted.
Yeah.
At the surface, I'd say right move, because maybe they were at the cold phase. But we know this person went to 3 hospitals to start with. Were there health professionals at those 3 hospitals? Then you come to the microcosm of the people who've been interdicted. Who are they? Under what conditions were they working? For example, were they just junior house officers or medical officers who had come in, who were trying to do their best under a bad condition? We don't know. So for me, and that is why I am not dwelling on who has been interdicted or not. For me, this needs to be investigated thoroughly again. And this time, the findings do not need to be shelved. The problem we have and have had is that when things like this happen, even though we don't deal with the diagnosis of our health system and its problems properly, when these happen and they give us an opportunity, because Richard and Co who are the medics will tell you that is what pathology is about. When the bad outcome has happened, they look at it, they have case reviews, pathologists look at it, cause of death and other things, and then they come out with mitigation so that these things do not happen again. I hope we are going to see that. I sincerely hope we're going to see that. And you know what? I hear the noises being made by the Ministry of Health. I hear the noises being made by the minister. And they are good noises because we need retooling. But at this point in time, these things have to happen quickly. Simple things like I was listening to one of the callers who said, why can't he go online and have a dashboard which tells him bed availability across the paste? Ordinarily, that should not be for the patient or the patient's representative to do. That should be available for the emergency services and the managers of the health system to be able to see across the pace. Because if an ambulance is carrying you, for example, and you have 70% beds, there might be a bed in a hospital where there's not a plastic surgeon or someone who can deal with beds. If there's a bed and it lacks the facility, you still have and that's why I said it's not a bed issue strictly. You send the patient to the wrong place and the patient cannot be dealt with.
Okay.
Did we not talk of this dashboard being available as far back as 2019, 2020, 2021, when we were doing the one ambulance, one district? Winston, was I not at pains with, at that time, Professor Zachary, who used to run the ambulance on the same program, and people called in to lambast me for saying that this was a fundamental requirement? You see, this is why I am coming from where I'm coming from. Now, unfortunately, someone has died, and sadly so. But you know the bigger thing? People are dying across the country as a result of our mutual negligence, collective negligence. Because some of these things that have to be in design, we never do them because we want the optics and not a health system that is delivering.
Okay.
And that is why we're here.
Okay. You made reference to the 2018 document, June 14. And I have that, press statement here. Let me just read bits of it. It says the Ghana Medical Association has followed with keen interest the public discussions concerning the late Prince Anthony Opoku-Acheampong, who is reported to have been refused admission by 7 different health facilities on account of no bed, resulting in his untimely death. We wish to express our deepest condolences to the bereaved family. This phenomenon of no bed syndrome has plagued this country for a long time, and we wish to state as follows. 1. The Ministry of Health must ensure the successful implementation of the Accident and Emergency Services Guidelines developed in 2011. That the no bed syndrome is a constellation of both largely systemic and, in some cases, individual factors. Some of the systemic factors include lack of functional emergency departments in hospitals and clinics, and lack of proper referral or feedback systems, and inadequate ambulances and dysfunctional ambulance system, lack of proper intra and inter-hospital communication, referrals and feedback, very limited bed capacities for emergency care, and deficiencies in bed management systems and patient flow in hospitals, ill-equipped emergency rooms, inadequate number of trained emergency room professionals and other support staff, lack of clear guidelines for triaging and managing emergency cases, and upfront payment for emergency services rendered. Now, let's get to the bit about, inadequate ambulances and dysfunctional ambulance system, because Dr. Simon Nyaba is back on the line with us.
Yes, so Doc, we're talking about the numbers of the Ghana Ambulance Service. Please, can you hear us?
Yes, I can hear you clearly.
Yes, so you mentioned that out of 318, 191 ambulances are working, about 127 ambulances have been grounded, right?
Yes, but I made reference to the fact that was just the availability as of yesterday in the morning.
Okay.
Just like anybody or any organization running a fleet of vehicles, you cannot have all of them functional at any given moment. However, efforts are ongoing on daily basis, to bring them back, to commission, because some of them are minor in terms of servicing, the regular servicing, and so day in, day out, some are being brought back into commission while others are booked out of commission for one reason or the other. And so the report of 191 out of commission from the total fleet of 318 was as yesterday in the morning. As we speak now, that information is being collated across the country, and so maybe later in the afternoon that will be available for you if that is required.
I remember that in 2018, when the president was petitioned in the no bed syndrome and the abandoned hospitals and the no emergency response system, the ambulance service had just about 54 out of 155 ambulances working. Due to that, the one constituency, one ambulance project was done, and your fleet was increased to about 350 something. So the ambulances that are grounded now, is it a mix of the very old ambulances, or some of the new ambulances also have challenges? Just for our education.
Okay, just put in context that the lifespan of the ambulance is 5 years designer, and the 5 years actually is not for the Ghanaian road conditions, and so you will agree with me that with the conditions of our road, that lifespan of 5 years will definitely be reduced significantly. And as you rightly mentioned, the significant injection of ambulances into the fleet was in 2019, late 2018, 2019. Now, if you take from 2019 to date, that means that all the ambulances, even those that were injected in 2019, would have passed their lifespan, and so they would have all have difficulties in one way or the other. And so as we speak now, most of our fleet actually they have passed their lifespan, and so there is an increase in terms of maintenance, the frequency of these ambulances in the workshop, rather than attending to cases that usually they would have been designed to do. So from 2019 till now, that's about 6 years. And we are in the 7th year of the most recent fleet of ambulances injected into the system. And so definitely they will have passed their lifespan.
How is the maintenance protocol like? Is it that the National Ambulance Service has a workshop that maintains this, or you give it to a third party business to maintain your ambulances for you? When it comes to the maintenance of our workshop, our fleet, within the service, we have auto mechanic workshops, but they are very limited. We have them based in Accra. We have one in Accra. We have in Kumasi. We have in Tamale. We have a workshop in Ho. We have one in Takrady. These are the only 5 auto mechanic workshops that we have in the country. And they undertake minor repairs and the routine servicing of our vehicles. There are efforts ongoing also to expand these to the other regions so that we will have auto mechanic workshops across the country where these minor repairs and the regular or routine servicing of our vehicles can be undertaken. Now, Doc, based on our own research, we've come to the conclusion that a lot of these vehicles in your fleet that are not operational is because you don't have the funds to buy your spare parts to maintain them appropriately. How is the funding of the ambulance service like? We know that based on the acts, you are to get some money from the NIC, from Road Fund, maybe from NHI. Do you get the required funding to run the ambulance service annually?
Definitely, as an agency under the Ministry of Health, we submit our budget through the Ministry of Health. And in terms of adequate, definitely no amount will be adequate to run any public service agency like ours. And so the process is we submit our budget through our mother agency, that's the Ministry of Health, to the Ministry of Finance. Approvals are given, and then allocations are done for that. Like I said, we cannot say.
Doc, let me help you here. I want to refer to the Act, right? The Act that you operate with, the National Ambulance Act 2020, if you don't mind. And if you look at the Act, for example, when it comes to finances of the service, it says that the funds of the service include monies provided by Parliament, a percentage of monies accruing to the National Insurance Commission in respect of insurance stickers for motor insurance as determined on an annual basis, and by the National Insurance Commission and the Ghana Insurance Association, monies from the National Health Insurance Authority, internally generated funds, donations, grants, and all those things. So let's focus on even just the Insurance Commission and the NHIA part. Do you get regular transfers from these two bodies to run the ambulance service?
As to regular from these two arrangements, I will ongoing arrangements in terms of the tariffs, among others. Some papers have been submitted so right with the National Health Insurance Authority, so that these things can be implemented in accordance with the provisions of Act 1041.
Before my colleague Winston comes in, I want to draw your attention to one more thing. In 2022, for example, only 29.8% of your budget was released. So less than 30% of your budget was released. How much of your budget, for example, for 2025 was released? Is there any year that your budget releases has even hit about 70%?
That definitely. As we speak now, I don't have the data readily available in terms of the percentage of our budget that was approved for last year. But that can be made available to you after this interview. However, like I said earlier on, we submit our budget to the Ministry of Health for onward submission to the Ministry of Finance.
Okay.
And then disbursement allocations and disbursement are made from the Ministry of Finance to us for our operational activities.
Now, Dr. Nyaba, you made reference to the fact that ambulances normally have a lifespan of 5 years.
Correct.
By design. And you would also agree that in some of the literature, you would realize that some ambulances, the lifespan is between 5 to 7 years. It's okay. You went for the least of them. But in there also, it talks about the fact that if properly maintained, it could last till 10 years.
Correct.
I'm just concerned, how is it possible that you have more than a third of your fleet grounded?
Several factors will account for this. And like I said earlier on, one is our road conditions. And from our research or even data that we have gathered here at the headquarters, is that some of the ambulances that are operating within the urban areas actually are in better condition than those that are in the rural communities because of the nature of the road, one. And so you would see that the fleet of ambulances that run in Greater Accra, Ashanti region, they tend to, or they last longer than those that are in the rural area because of the rough nature of the roads. And the referral centers also are closer because, for example, if an ambulance is leaving Bolgatanga with a patient, they will have to be referring or transporting this patient all the way to Komfuanoche or Tamale Teaching Hospital or even Accra here. And so they tend to make very long, they cover long distances. Whereas within Greater Accra here, if you pick a patient, it's either a short distance to Ridge Hospital, UGMC, Kolebu, among others. So those in the urban areas, they cover shorter distances at any point in time, whereas those in the rural areas, besides the rough nature of the roads, they also cover long distances, contributing to wear and tear of those vehicles.
And is that not the more reason those ones should be maintained regularly to ensure that they are in good condition?
Correct. There is need for regular maintenance.
Okay.
There is the program for that also. It's just that, we alluded earlier on, there are several constraints why these things have not been undertaken as planned.
Talking about constraints.
Another factor also that actually is the fuel.
Yes, I was coming to
the
that.
rural areas, the fuel, and then the injectors. Most of our vehicles are down because of the injectors. And I think it's from preliminary information that we have gathered is that sometimes the quality of the fuel also impacts on the functionality of these injectors, and so the injectors tend to wear down because of the quality of fuel that we use generally in Ghana.
But Dr. Nyaba, so this one, if you know, and the economists say a problem well defined is half solved. If you know that low quality, contaminated, or improper fuel could cause significant damage to injectors, what have you done about that?
Well, the thing is, definitely, as a service, we have identified what the problem is, and appropriate measures have been put in place. Listen, the report of such have been forwarded to appropriate authorities for due action. You will also agree with me that we do not have options in terms of where we procure our fuel. It's only one source, and that's the government source that we procure our fuel for the fleet of ambulances. And so in that regard, we do not have the choice really to say that...
you procure, hold on, you say you procure from a government source?
Correct.
And you said earlier that you have issues with quality fuel.
Quality of fuel from that government source?
No, I was just mentioning or adding to some of the factors that account for the breakdown
yes, but you see, please hold on, Dr. Nyaba.
Yes.
You talked about the factors. You say low quality fuel. Hold on.
Correct.
You say the fuel is part of the problems with your injectors. And you're telling us that you acquire the fuel from a government source. And so I'm asking.
Correct.
And so the fuel that you acquire from a government source is creating problems, which means if you know the source, you can actually deal with this problem, isn't it, Dr. Nyaba?
Correct. That is correct. But like I was saying, what I was arriving at, if you had allowed me, was that because we have just one source, that is the government source of fueling our vehicles. Now, you will agree with me that we have ambulance stations across the country, and even in most areas where the government fuel sources do not have stations or filling stations. And so they are resorted to actually procure or use fuel from other sources that we cannot actually defend as being of the quality that is required. And so I'm just saying this is data that we have gathered here.
And based on Dr. Nyaba, based on the data you've gathered, have you informed the National Petroleum Authority on this?
Reports have been put in place.
Have you reported to the National Petroleum Authority? I want to be able to check with them. That's why I'm asking. I want to be specific. Have you reported to the NPA?
I cannot speak to as to whether directly with the National Petroleum Authority that the report has reached them.
Okay. But reading messages, people have actually complained that there are times, and I've experienced it before, they call the National Ambulance Service and they ask for fuel.
Okay.
You know that?
Yes.
Why do you ask people for fuel?
Yes, the fact of the matter is that the fuel that we have as allocation for every ambulance per month is not sufficient or cannot be sufficient to provide free services all across. And so sometimes, and that is why they will call it fuel support, not a fee charge. Is that, for example, if an ambulance is provided with, let's say, 7,000 Ghana cedis, I'm just citing an example, 7,000 Ghana cedis worth of fuel for the month. Now, depending on the cases that they attend to, like I mentioned earlier on, an ambulance will leave Bolgatanga, for example, with the patient, all the way to Komfo-Anokye. Now, just that trip and back, they would have exhausted much of the 7,000 that is allocated them. If they make 3 of these trips within the month, or which could even happen in 2 weeks, they would have exhausted the fuel that is allocated them for the entire month. Now, what happens for the remaining period of the month? And that is why sometimes there will be the request for support in terms of fuel to transport the patients to the definitive areas of care for continuum.
Okay. Let me bring in Dr. Richard Salome. And Dr. Salome, I've been reading the letter or the press release from Professor Titus Bayo. At the time, Dr. Titus Bayo on what had to be done. I mean, let's look at the solutions. We've talked about the problems. How do we deal with these challenges?
Well, Winston, I've spent the period listening to you and then the National Ambulance Service. Again, we need a well-coordinated system.
Okay.
Like my brother Kwame has said, we have seen some positive actions by our Minister of Health, and we must commend that, especially when it comes to retooling. Especially since 2014, no proper retooling has happened. We also acknowledge efforts by the previous administration to procure ambulances and a few other measures that were put in place. But if we are really serious about this matter, to deal with this matter, we need a holistic approach to the matter, dealing with the human resource issues, dealing with retooling, equipment, logistics, dealing with coordination, and then dealing with monitoring systems and other systems that encourage the public to improve their health-seeking behavior and also support and own their response system. Remember, we've talked about the fact that there is a need so that if you go to a facility and you need to move to another point or you cannot get the care you need over there, there should be a system so that before the vehicle moves or the ambulance moves from, say, Ridge Hospital, it knows and it is assured of a bed at, say, UGMC or Kolebu. The doctors who need to see this patient would have been pre-informed, and if it is a surgery, for example, the anesthetist, the nurses, and everybody is ready and waiting for this patient to come. And then feedback goes all the way back to the facility that is being referred. That is when you have a closed loop of referral where there's coordination from the starting point to the end point and back to the starting point again.
Okay.
Until we fix all these building blocks, the public, the human resource, logistics, equipment, as well as coordination systems, and then the monitoring and evaluation systems, we will continue having this conversation. And I was with Titus then also as an executive when we worked on this statement and released this statement. You notice that the solutions therein are things that we have overflowed for years now. I must commend you as Joy FM for bringing this issue back, but of course it is after another incident. What we also expect is the public should take ownership and demand that these issues are improved and not just get into this cyclical runs, then we go back till another patient is lost, then runs, then we go back. No, we must all be invested. If we are serious about this matter, we must all be invested. Demand from your MP what is being done about this situation. Demand from your leaders accountability on this matter. And where people are found culpable, of course, let the rule take its course. And I'm happy, Kwame said, that our colleagues in Kolebu, the Ghana Medical Association, does not condone any wrongdoing. And we have always said that we do not stand in the way of any investigations that seeks to bring out challenges and solve problems. And that is why we are happy with the composition of the team that the ministry has put together, seasoned professionals to look into the matter. But we also do not want it to be seen as if the nurses and doctors involved there are the only people and the problem, and we are looking for scapegoats to punish, rather than use it as an opportunity to solve a systemic problem. In other places, when issues like this happen, laws are even passed and big changes happen because of things like this. And it will happen when we have consistent effort and focus on the matter to solve it. And I hope Joy FM will take this as a big project where you are tracking this matter, giving us, for example, a regular update on ambulance situation in the country. This really matter, follow it up, follow the funding, for example, to be sure and put the necessary public pressure that the funding releases to the ambulance services go. The peripheral facilities are equipped so that we don't always have to dump to Kolebu Ridge Hospital and 37, where you will never have enough beds. And then also making sure that the health professionals are properly trained, resourced, and motivated to do the work. Where they are understaffed, already demotivated, and also the place is choked, patients are on the floor. Sometimes they do their best, and then we come back again and say, yes, we came there, patients are even being nursed on the floor. Now, when the person gets into that fix, he feels, can I rather nurse this patient on the floor, or should I let the person go to a place where they can be better cared for? And then some of these situations lead people to take certain decisions that may not be in the best interest of the patient. And so let's tackle this issue from a systemic point. Again, to reiterate, we need a well-coordinated emergency system, a unified triaging system where when we triage the person, we can know that this person needs this care is available here and there. Real-time bed tracking, so that if we are in Accra, we should know, for example, the number of beds available at every single time. And I believe that if we are minded, I believe the ministry can drive this and put some small money there for a hackathon. There are many IT professionals, great professionals in the country that can take this up. If the health insurance can bring to the ministry, to get people to put an application together so that at any time we can track how many beds are in Accra and every city in the country.
Okay.
Then we need bed managers who will be able to track these changes and also coordinate with other facilities to ensure pre-ambulance arrival coordination should also be properly done. And again, regular review and monitoring of these matters. Of course, all of this will go with some money, and therefore, if we are serious, we need to have some dedicated, possibly ring fence financing to take care of all of these matters so that we don't come back and be flogging the same matters again over and over. We are hoping that the way the minister has started well, he will continue that. But of course, we are ready and willing to partner as Ghana Medical Association to ensure that the system is improved to care for both you, myself, and the general public as well.
Thank you, Dr. Salome. Let me bring in Kwame Sapon-Asiedu. Kwame, in a minute, by way of solutions, what should be done?
Winston, yes, you've made it easy for me. We have the Health Harmonization Assessment Report. Richard has gone through it, what it tells us we have to do. That's the point I'm making. We have the diagnosis already. We know what we have to do. So I don't want, and the letter you read from 2018 contains what we have to do.
Okay.
It has been reiterated again. All I'm trying to say is we shouldn't leave it. Look, this is how I'd end it. That document was written in 2011. In June 2018, it was said that we need to implement it. That was 7 years after. 8 years after, we are sitting here saying it has to be implemented. You know how much it is? It's taken us 15 years to implement a document, and we are still shouting. And that document was put in place because there was a shout because of a supposed no bed syndrome. So what I'm trying to say is, like Dr. Salome said, the minister started well, he should continue. This has to be implemented. Once it's implemented, it solves the system as well as the people problem. And that would be how we would fix this. Otherwise, we'll continue shouting. Thank you.
Thank you very much, Kwame Sapon-Asiedu. Dr. Nyaba, how do we solve these problems in a minute?
Well, from our point of view in the ambulance service, our challenges are quite significant also in terms of, as we mentioned, the fleet. You know, if you look at considering the population of Ghana presently, we are operating the fleet ratio of 1 ambulance to 100,000 of our population, against the benchmark of 1 ambulance to 25,000, you know. In terms of infrastructure, unfortunately, we still have some districts in the country that do not have ambulance stations. Oxygen is one of the major commodities that we use in our ambulances. And as we speak now, we do not even have an oxygen plant of our own. We rely on external sources, and sometimes when they have shortages of their own or they have operational issues, then we have difficulties in that regard. You know, but the main issue, I would say that we lack a sustainable, reliable, and dedicated source of funding in terms of our operations.
Okay.
That will allow for some kind of fleet renewal program. It will allow for development of the infrastructure, you know, or educational programs that we have charted as a way forward in addressing some of these challenges.
All right, Dr. Simon Nyaba, who's Deputy Director, Policy Planning, Research, Monitoring and Evaluation at the National Ambulance Service, Kwame Sapon-Asiedu, pharmacist, and Democracy and Development Fellow on Health, and also to you, Richard Salome, General Secretary, Ghana Medical Association. Thank you very much for joining us this morning. We're grateful.